Alright, so welcome to Road to 250. Today's just a bunch of review questions. So let's get going. I think this one was still sees.
Yep. If a 48-year-old woman suffering from a severe tension headache is brought to the emergency department after her husband discovered her unresponsive and barely breathing when he stopped at home from work during his lunch hour. A bottle of Vicodin is found near the bathroom sink. Which of the following arterial blood gases are most consistent with her clinical presentation?
So she's going to be acidotic from decreased respiration.
Mm-hmm.
So A, B, or C. PaCO2 is going to be elevated, so A or B. And then bicarb, B.
Decreased.
Low,
So
B. Because it would be a respiratory acidosis, not metabolic. Oh, no, wait.
It would be metabolic acidosis.
Yeah.
Why metabolic?
Okay, so
she's on opioid because opioid is going to cause decrease in respiration, which would be a respiratory acidosis.
Well, the only reason A or B doesn't make sense to me is because if you increase the PCO2, yes, you will become acidotic, but doesn't your bicarb have to get higher?
Yeah.
So in B, your bicarb is low, and in A, your bicarb is normal. So if you are on respiratory acidosis, shouldn't your bicarb be higher? Like D, for example, if it was 60 and 38 with an acidotic pH, that would make more sense in respiratory.
Okay, so
as a compensation mechanism.
But compensation takes time. This lady's probably only been knocked out for a few hours. Well, A or B, I don't know, I guess. I guess I go with A because a pH of 7.02 is like ridiculous.
Yeah, that doesn't make any sense. That's way too low.
A?
Yeah, I mean, if it's respiratory, because it's an opioid, right?
Yeah, so you're going to have respiratory arrest.
So it's A. It's got to be A, respiratory.
So the answer is B. The next slide has the complete answer.
So did you have the Na concentrations and all that in the the question?
No.
Okay, but okay.
High anion gap metabolic acidosis results from increase in unmeasured organic ions. Is critical. Oh, well, COPD and myasthenia gravis are causes of respiratory acidosis. So, wait, what?
But are they assuming that this person has like lactic acidosis? Like anything with mud piles doesn't make any sense here.
One sec.
Hang on, go back to the question. Did she have a severe tension headache?
Hold on. Maybe I have messed up.
Unless the...
Oh, wait. Yeah. Okay, I have it messed up. Sorry. The answer is A.
Okay. Yeah, I was going to say.
I'm sorry, I got confused with two different questions that I was trying to go through.
I feel like the explanation is trying to say that the explanation would say that she's having a metabolic acidosis.
Yeah, okay. So the answer is A. Narcotics used for treatment of severe headache may depress the medullary respiratory center, causing alveolar hypoventilation, and as evidenced by elevation in the arterial PCO2. So hypercapnia lowers the ratio of bicarb to dissolve CO2 in the plasma. and thus lowers the pH according to the Henderson-Hasselbalch equation. And then renal compensation for respiratory acidosis takes hours to start and days to be complete, and thus there has not been sufficient time for the body's compensation mechanism to take effect for plasma bicarb to rise. Thus, the scenario is most consistent with an acute, uncompensated respiratory acidosis. The slight rise in plasma bicarb concentration can be attributed to the extracellular buffering of excess hydrogen.
Okay.
Sorry about that.
All right. No, it's good. It's good.
All right, next one should be a little more simpler. A 72-year-old female presents to the emergency department with a generalized weakness. A ECG reveals peak T waves. Which of the following electrolyte disturbances should be corrected to return the ECG to normal?
A.
Yeah, hyperkalemia.
Yes, that'd be right.
Boom. And then, is it you get flattened T waves with hypokalemia, right?
Mm-hmm.
Yeah, cool. All right, we have a 23-year-old gravida woman is pregnant with twins at 11 weeks gestation. She's experiencing nausea and vomiting of moderate intensity. So it's worse in the morning. She has tried non-pharmacologic therapies with limited success. She's also tried drinking and eating small amounts at the same time and staying away from odors that make her feel nausea. That should be nauseous. This patient's labs would demonstrate what abnormality?
Vomiting. So, metabolic alkalosis?
Correct. So, this is called hyperemesis gravidarum, when women have severe vomiting that's uncontrollable. And actually, the way to test if it's like just normal, like morning sickness, or if it's like severe illness, is you do a metabolic panel like this, and you also check the urine for ketones. And if they have ketones in the urine, you have to admit them to the hospital right away to normalize their acid-base status. So yeah, I got that question, and I thought, why not? This kind of ties into what we were chatting about with the acid-base crap.
What was it called again? Sorry.
Hyperemesis gravidarum. All right, so we got a 34-year-old female presents to OBGYN clinic stating that she and her husband decided to get pregnant and would like some prenatal advice. She has been on OCPs for menorrhagia control since she was in her early 20s. The patient's medical history consists of sarcoid disease treated with hydroxychloroquine and Hashimoto's thyroiditis controlled with levothyroxine. In addition to stopping OCPs and beginning prenatal vitamins, what additional advice should her physician give?
Be her boy.
Anything else?
D.
Or anyone else?
D. Because going back to what you had yesterday, Tulsi here, TGB would increase, or TBG would increase, and thus you would need to increase.
Yeah, so I heard you were doing thyroid stuff yesterday that I missed, and
Yeah. So the whole
is,
sarcoid disease, don't they have like an increased vitamin D? Okay, maybe I'm thinking the wrong thing.
well, so hydroxychloroquine is safe
Yeah.
in pregnancy,
Mm.
so you don't need to do anything with that. But Yash is correct with D, and his rationale is correct because thyroid binding globulin
Pregnancy.
increases in pregnancy. So once you become pregnant, you have to increase your dose,
Yeah.
or else both you and baby can become hypothyroid, and they'll present with fetal growth retardation and premature labor.
Mm-hmm.
So it's about 1/3 of your dose needs to be increased, but I guess it's like titrated patient to patient. But yeah, increase C levothyroxine.
All right, so we have a 55-year-old woman that comes to the physician because of tingling, burning, numbness, and muscle weakness in her lower leg. The sensation started as tingling and burning in her fingers and toes 1 week ago. She had an acute episode of bloody diarrhea 2 weeks ago. Examination shows a loss of deep tendon reflex. Cranial nerves are intact. A nerve conduction study shows a slower nerve conduction velocity. As her disease progresses, which of the following acid-base disorders will most likely develop?
A for apple.
Okay. Anyone else? What do you think she has? What do you guys think she has?
Yeah,
Diabetes or peripheral neuropathy.
So key things to keep here, obviously, are the symptoms. This is a key. 1 week ago, and now has progressed to her lower legs.
So,
And then she had a bloody diarrhea 2 weeks ago.
Guillain-Barré.
Yeah, she does have Guillain-Barré.
So she's gonna end up with a respiratory acidosis. D.
The answer is D. And it's because the conduction velocities are lowered, and then she also has bilateral mixed sensory and motor loss. So as I said, it started distally and then progressed proximally, so toes and then to the lower legs. So it's a demyelinating disease of peripheral nerves, and then, as we all know, leads to hypoventilation because that's the complication. And that will increase the CO2 retention and respiratory acidosis. With A, diabetes would be a good, ketoacidosis would be a good differential for metabolic acidosis with increased anion gap, but it's just the wrong disease for this one. Does anybody need explanations for any of the other answer choices? Okay, then we'll move on to the next one. Respiratory acidosis is a major complication in morphine overdose. Which of the following labs data corresponds to pure respiratory acidosis? Oof. Sorry.
So it's either A through D.
Yeah.
CO2 would be elevated, so we can go with C or D. I guess we just said bicarb would be slightly increased, maybe, based on Tulsi's thing.
So D.
D is the right answer. So yeah, you didn't even have to calculate the anion gap. I don't know why they add that in there to throw you off, but yeah, your rationale of how you guys broke that down is correct.
Well, but if for respiratory acidosis, you don't need to bother with the anion gap because that's only to distinguish metabolics.
Yeah, they just try to throw you off with that.
Not this group. Oh.
Yeah, so you guys good? If you need corrections, I can stop for a second. But I think you guys got that down pat.
A 6-year-old boy has a history of 5 bone fractures, 3 of them occurring only after minimal trauma. His birth was unremarkable following a normal pregnancy. The patient has been in the 50th percentile for both height and weight since birth, and he has reached all developmental milestones. On physical exam, he is a pleasant, interactive child with small, malformed teeth. Further evaluation shows the finding in the image below. This patient's condition is most likely associated with impairment of which of the following processes?
Is this a UWorld question?
Yes.
C for cat.
B.
C, I think.
The answer is C.
Oh, yay!
So the B, mineralization problems would be related to a vitamin D deficiency.
Okay.
And with osteogenesis imperfecta, we have a type 1 collagen defect, and type 1 collagen is the predominant collagen in osteoid, which is the organic portion of the bone matrix.
Oh, okay.
And this is your bone lecture from way long ago.
Yeah.
So what is the mechanism behind the blue sclera?
You have, your connective tissue is deficient, so it's your sclera is transparent, so you can see the underlying vessels.
The choroidal veins, I believe, yes.
Yeah, choroidal veins. You can see those.
A 27-year-old man comes to the emergency department due to several hours of right foot pain and swelling. Last night, he was working in the barn and stepped on an old nail. This morning, the patient awoke with right foot pain near the injury site that has increased throughout the day and is accompanied by progressive swelling. He has no significant past medical history and takes no medications. Temperature is 100.6, BP is 135/75, pulse is 95. The right foot is swollen with some erythema around the injury site. Radiographic imaging reveals gas in the tissues. On urgent surgical exploration, extensive tissue necrosis is present. Culture from the site reveals gram-positive rods. Which of the following best describes the mechanism of action of the toxin responsible for the necrotic effects seen in this patient? So it helps to figure out what organism is affecting this guy first. Does anybody know?
Clostridium perfringens is what causes the gas.
Gas, yeah, and the crepitus.
And what toxin does Clostridium perfringens have?
Alpha toxin.
Right. And
So is this the guy
A?
let's see, B? Don't they use carbohydrate as their food source, and then like the gas from it? Oh wait, no.
It's
No,
D.
no, it's D. Yeah, phospholipids. That's what they use for their food.
the correct answer is D.
Yeah.
They
Good
do use carbohydrates for energy.
Right, but the phospholipid is where the gas comes from. Yeah.
Yeah. So it's, the alpha toxin is also known as lecithinase, and lecithin is a phospholipid. So that's where your degradation comes from. And yeah. You need to explain any of the other ones? No?
Well, because I was at first thinking it was going to be F, because it was looking like you were going to talk about tetanus, but then you busted out gas. And, well, in the question, not out of your butt.
Yes.
Wait, hang on. What's the name of the important sphingomyelin in for lung maturity? What the hell's the name of that?
Phosphatidylcholine. I think phosphatidylcholine, serine.
Yeah, phosphatidylcholine.
I always mix them up.
Yeah, some long ass word.
Serine is one of them is for the caspases, and then one is the sphingomyelin thing.
Yeah.
But it's also like DPP, something like that.
Diphosphatidylcholine, some shit like that.
Yeah.
Fun stuff.
All these fun words in medicine. I just did the neuro section last week and got reintroduced to
Diadochokinesis.
dysdiadochokinesia. Yeah.
Yes.
What a great word.
I have a challenge question for you guys.
Oh boy.
So a 46-year-old woman comes to the physician because of primary biliary cirrhosis. Lab studies are shown. pH is 7.3. PCO2 is 29. HCO3 is 15. Sodium is 129. Potassium is 3.1. Chloride is 105. And the normal values are on the right side. So which of the following is most likely to cause this patient's acid-base disorder?
So we want to take 129 minus 105.
It's 24.
24 minus 15. Then 9.
Yeah.
So we have a
Increase.
normal.
8 to 12.
Yeah, 8 to 12. So we got a normal. So not mud paws. We got to go with hard ass.
Yeah.
So it's not A, it's not C, it's not D. Spironolactone is one of the S's. Furosemide, that's
Primary biliary cirrhosis.
now diuretics are in alkalosis, so I would go with E, I guess.
E, yeah.
I got that question wrong as well.
No. Oh, so it is furosemide?
The answer is C.
Inadequate ear.
Because,
Acidification.
yeah, so this patient has, as you guys pointed, metabolic acidosis, so that's correct. But with spironolactone, what's the side effect? Or
Oh, you're going to potassium sparing.
hyperkalemia.
Yeah.
So that's the reason why that's wrong. Obviously, chronic vomiting is metabolic alkalosis. Furosemide is metabolic alkalosis as well. And then lactic acidosis was metabolic acidosis, but with a greater anion gap. Now, the other thing you guys forgot to do is the Venters formula in this patient. So this patient has a mixed disorder. Because when you do the Venters formula, you'll get a value of 30 to 34 as what the PCO2 level should be. And in this case, the PCO2 is lower than 30.
Mm-hmm.
So, but wait, what is the inadequate urine acidification as the answer? I don't understand that.
So
What?
I didn't as well, but I just basically understood that the side effects of spironolactone would cause this to be higher. So that's the only one that made sense in this question.
So it's literally just a answer of exclusion?
Well, they said that inadequate urine acidification is a renal tubular acidosis type 1.
Oh, motherfucker. Yeah, that's the R in hard ass, isn't it?
Yeah, so that's the connection between that, and I didn't pick that up myself.
Oh, that's a tough one.
Yeah.
Yeah,
So,
I've never been good at kidney stuff.
yeah. Apparently with type 1, it's inadequate urine acidification, and then with type 2, it's renal bicarbonate wasting. But when I learned renal tubular acidosis, I heard the way I learned it for type 1 was this number would be less than 10. So I didn't look at that value as 15 as a renal tubular acidosis. But I guess based on after knowing the answers, that would make sense.
Yeah, but yeah, that makes sense because I learned with type 1, you got bicarb, sodium, and potassium are all low. I just remember learning that everything's going to be low because nothing is getting reabsorbed in PCT. So,
which renal tubular acidosis is hyperkalemic?
Oh, I don't know.
Type 4.
Type 4.
3. Oh, sorry. Yeah, type 4.
Type 4 is hyperkalemia. So that's one section I kind of skipped over because I would just add too much to it. But yeah, this is type 1. Okay. So a challenge question for you.
Yeah, that's challenging.